the world to move swiftly to provide the necessary data that will allow us to consider them for emergency use listings. I'm pleased that the WHO team is in China currently working with producers of the Sinovac and Sinopharm vaccines to assess compliance with international quality manufacturing practice ahead of potential emergency use listing by WHO. To clarify, this is separate from the WHO origins mission. We also look forward to Serum Institute of India submitting full data sets for rapid assessment so WHO can determine whether we can recommend their AstraZeneca vaccine for international use. These are just a couple of examples of work underway by WHO, Gavi, CEPI, and other partners aimed at safe, rapid, equitable, and wise allocation of vaccines. As I have said before, and will say again, saving lives, livelihoods, and economies depends on a global agreement to avoid vaccine nationalism. Over the weekend, WHO was notified by Japan about a new variant of the virus. The more the virus spreads, the higher the chance of new changes to the virus. Most notably, transmissibility of some variants of the virus appears to be increasing. This can drive a surge of cases and hospitalizations, which is highly problematic for health workers and hospitals already close to breaking point. This is especially true where public health and social measures have already broken down. This can have a knock-on effect on other essential health services. At present, the variants do not seem to show increased severity of disease. With new treatments coming down the pipeline, we're hopeful that more lives of those with serious cases of COVID-19 can be saved. But we need to follow the public health basics now more than ever. Keep as much physical distance as you can from other people. Keep rooms well ventilated. Wear a mask. Keep your hands clean. And cough away from others into your elbow. You might get fed up of hearing it, but the virus is not fed up with us. Limiting transmission limits the chance of dangerous new variants from developing. What's most critical is that we sequence the virus effectively so we know how it's changing and how to respond. For example, while diagnostics and vaccines still seem to be effective against the current virus, we may need to tweak them in the future. Last week, WHO released a comprehensive implementation guide and risk monitoring framework to help countries set up high-impact sequencing programs. We call on all countries to increase the sequencing of the virus to supplement ongoing surveillance, monitoring, and testing efforts, and to share that data internationally. This helps us better understand when variants of concern are identified. We're aware that sequencing requires specialized equipment, a trained workforce, and close collaboration between experts. Building upon our existing lab networks, WHO is working with countries to enhance sequencing capacity, and we extend our support to all countries who need it. We achieve much of this through our international network of labs for SARS-CoV-2 and influenza flu lab network, both of which have been a beacon of science, solutions, and solidarity in the last year. Tomorrow, WHO's R&D Blueprint Group is convening scientists from around the world to set global research priorities for the year ahead, including on virus variants and sequencing. This builds on a year's worth of work defining and delivering on an R&D roadmap for COVID-19. Just as we look forward on research and rolling out vaccines, we continue work on the origins. We're pleased that an international team of scientists, distinguished experts from 10 institutions and countries are commencing their travel to China to engage in and review scientific research with their Chinese counterparts on the origins of the virus. I want to thank all GORN partners and the countries supporting this mission. This includes Australia, Denmark, Germany, Kenya, Japan, Netherlands, Qatar, Russia, Sudan, the United Kingdom, the United States of America, and Vietnam, and our colleagues from China. Studies will begin in Wuhan to identify the potential source of infection of the early cases. Scientific evidence will drive hypotheses, which will then be the basis for further long-term studies. This is important not just for COVID-19, but for the future of global health security and to manage emerging disease threats with pandemic potential. We will share more news as we have it, but let's give this team of scientists the space to work with their Chinese counterparts effectively, and let's wish them all well, and expressing our respect and appreciation to these distinguished scientists and experts. I thank you. Fadila, back to you.
Thank you, Dr. Tedros. I will now open the floor to questions from members of the media. I remind you that you will need to raise your hand using the function raise your hand in order to get in the queue. I would like now to invite Bayram Atuk from Anadolu News Agency to ask the first question. Bayram, are you with us?
Hi, thank you, Fadela, for taking my question. I have a short question, actually. As WHO, have you set up a concrete date or timeline for delivering vaccines to 92 low and middle income countries through COVAX facility? And if your answer yes, which countries or regions are primarily on your emergency list? What's your plans? What's your plans on this issue? Thank you.
Thank you, Bayram. I would like to invite Dr. Bruce Aylward to answer this question. Dr. Aylward.
Thank you very much for the question. As I think everyone on the call is aware, over 40 countries have now begun vaccinating against COVID-19 using 5 different COVID vaccines. However, all of that vaccination, or virtually all of it, as the Director General has emphasized, we're in the high-income and upper-middle-income countries so far. We're working very hard, as we've discussed in last week's press conference, to try and accelerate now the rollout of vaccines through the COVAX facility, and especially for the AMC countries. We expect and we have strong confidence that we should be able to be vaccinating in February in these countries, and we're doing everything possible to make sure in as many countries as possible, but we cannot do that on our own. We require the cooperation of vaccine manufacturers to prioritize deliveries to the COVAX facility. We require the cooperation of our financiers to see through the financing necessary, and we require the cooperation, as Dr. Tedros said, of those key suppliers to make sure that we have the necessary data to ensure these vaccines meet all of the criteria necessary in terms of efficacy, safety, and quality. Now, we are also looking, are there some extraordinary things we could do to even bring that timeline a little bit further ahead? And we have a great ambition, actually, to try and do something even in January. But again, there requires the cooperation desperation of a lot of other players, particularly the suppliers, to prioritize the COVAX facility, and not the COVAX facility, but really the AMC countries to be receiving vaccines, because right now we have an inequitable situation where vaccines are going to high-income countries, upper-middle-income countries, and not yet to the lowest-income countries. This is not something that the COVAX facility fully controls. We're doing everything possible to advance that. In terms of the specific countries, the countries are at different level of preparedness to roll out and readiness to roll out COVID vaccines. So we are in the process of working across all members of COVAX, and especially the 92, what we call AMC countries, and that's the advanced market commitment countries, or for those of you who don't know, the countries who are eligible for support through COVAX for their vaccines. So we're working through all of those, and I'm going to ask Kate to say a word about that to ensure their readiness. Now, as we go out to countries, they come back and they tell us when they would like to introduce their vaccines, when they will be ready to do that, what kind of vaccines and how many they might like to use, et cetera. So we have to take all of that information together to look at the schedule of how the vaccines roll out. And then we have to match that against the supply side, as I just mentioned. Just last week, the COVAX facility wrote out to all of the countries again on the 6th of January, asking for updates on their readiness plans and their ambition in this regard. So we hope to actually have that rollout plan of what countries and when later this month. So all of these things moving fast. The critical piece we need now is to work with the manufacturers to make sure we have the vaccines for these countries. But Kate, you may wish to add on the readiness piece.
Thank you, Bruce. The country readiness, I think it's not lost on anybody how critical the country readiness is. We've been hearing about high-income countries that are working really hard but struggling to actually deploy the vaccines that they have and to deploy them with speed and with prioritization that the countries have made. So I think we really cannot underestimate the task that it is for a country to be ready to start to deploy any of these vaccines. In particular, vaccines like the Pfizer vaccine that does require special cold chain processes, an ultra cold chain, so keeping it at between -60 and -90 degrees. So this is not for the faint of heart. The areas of country readiness that we're working directly with countries on have to do with their regulatory process. Not only will products need to have this review by WHO, but countries also need to have a way to authorize the importation of the products. We're working with countries on training of healthcare workers so that the dosing requirements, the engagement with patients is appropriate for the vaccines that we have. Countries do also need to choose who the priority groups will be. With these limited number of doses that will come initially, there does have to be a decision in the country about what that prioritization will be. And we are, of course, very strongly recommending that it is health workers who are at high and very high risk of COVID disease, and older age groups who are also at high and very high risk of serious disease or even of death. And I mentioned the cold chain. So every country does have to make a plan and start to execute the plan for assuring that there is capacity within the cold chain to handle the influx of the vaccines, and safety monitoring of the administration of the vaccines, as we've assured and continue to emphasize that every vaccine program has a safety monitoring system, and doing anything that can be done in order to assure from the very beginning that there is the monitoring of the doses that are administered, and should there be an event, that there is the capacity at the site to deal with that health issue. And finally, it sounds like a bit of a boring thing, but the data system is really critical because these are 2-dose regimens. There does need to be a way for these adults to be recalled back, for them to know when they need to get their second dose, and for the whole program to know whether those second doses are being given in the time frame they're supposed to be given, and to make sure that the people who are being vaccinated are getting the full benefit of the vaccine program. So these are all areas for which WHO is working very closely with UNICEF, with Gavi and other partners. We've developed guidance and training materials and, frankly, simulation exercises for countries to start to practice and to rehearse and to identify whether or not the systems are in place to be able to deliver these vaccines, which are critical for the highest priority groups to receive in the time and the way that they need to be received. So those are the areas we're working on.
Yeah, thanks, Fidel. If I just come back on one point, it sounds complicated, but the reality is we are ready to start vaccinating in the AMC countries. The challenge is threefold. One, the manufacturers prioritizing supply to the COVAX facility, and also prioritizing that they get the information to WHO to be able to ensure the safety, efficacy, and quality of the vaccines. And so far, I think as most of you are aware, there's only one manufacturer that had submitted those data early enough that we could make a decision on it, and that was the Pfizer vaccine. We're delighted that others have now submitted full data. As the Director General said, Sinopharm has submitted its full data, and we're looking at others, we hope, in the near future. So that's one piece. Second, the countries that do have access to and are controlling the supply of the products that we know are safe and efficacious, et cetera, they can be sharing doses or they can be donating doses through the COVAX facility so that we could roll out to other parts of the world. And then third piece is that the countries, as Kate would say, who will be using these products can actually put them to good use immediately. And that's complicated because our motto is no dose lays idle anywhere in the world. But frankly, the measure of the world's commitment to the equitable rollout of these products and our common commitment to this battle against COVID will be, the best measure of that will be how quickly the COVAX facility can vaccinate, because we need a world committed to that to make it happen.
Thank you. I would like now to invite Corinne Gretler from Bloomberg to ask the next question. Corinne?
Thanks for taking my question. I have one for Mike today. In August, you said Sweden did a good job in its fight against COVID. And I just wanted to check if your views have changed in any way during the second wave. As in, was Sweden maybe too slow to implement non-voluntary measures? And what would you say are the lessons to be learned from the Swedish approach? Thank you.
August seems like such a long time ago. I think if I recall my comments at that time, I was being asked about the Swedish approach. And I was, I think, articulating at the time that each country had to define its own control measures based on the relationship of the social contract with its own population, and that measures that governments would put in place had to be acceptable to citizens. I think that at the time, the Swedish government in the first wave very much relied on its own population to implement the basic measures of physical distancing and hygiene, and was relying too on the fact that many people in Sweden lived in single person households. There wasn't as much mixing in that environment, and to an extent was really relying on individuals and communities to implement behaviors that would reduce the risk of transmission. And I think at that time I did reflect on the fact that demonstrated the kind of relationship that governments needed with populations in order to be successful in sustaining a long-term process of this kind of new normal. And I still stand by that. I still think we need those kinds of contracts where citizens implement without coercion and without being forced the kinds of measures that are in the interest of their health, their community's health, their family's health. I think the Swedish government themselves, the Swedish officials, did say, like many around the world, that a number of issues were missed during those first and possibly second waves. Was protection of older persons, particularly those living in long-term care facilities, the specific issues related to migrant communities that lived in different social circumstances. We saw this in Sweden. We saw this in the Emirates or in the Gulf states. We saw this in Singapore, where particular groups, particularly migrant groups, were subject to higher levels of transmission because of the environments in which they were living, dormitory-type conditions, multifamily dwellings, etc. So all countries missed some of the key elements in a sense and learned those lessons in the first and second waves. And I do believe that this time around Sweden has implemented further measures, and some of those measures have involved more government-mediated measures, including the government advising and going beyond advice to more strict enforcement of public health measures. And again, it still comes back to that idea of what a government believes is the right way to behave with regard to its own population. These are democratic states, and they have to determine. Sweden is a very particular contract with its population. They believe they are acting in good faith and in reflecting the will of their people. That changes over time as the severity of this pandemic has changed, as the implications of this pandemic have changed. And I believe the government of Sweden and its population have made good decisions in moving towards probably stricter measures because that is what the pandemic is telling them and because it has been difficult to sustain those purely voluntary measures at societal level, which would be true of any country. And I think it is an example of how difficult it is to sustain public health and social measures that are purely determined by the individual's willingness or determination to carry out those measures. And it somehow tells us, I think, at the beginning of 2021, how difficult and how challenging that environment is. But we have no other choice. Right now, we are faced with the prospect, as Kate and Bruce have so eloquently outlined, we have a real prospect, if the right things are done by governments, if the right things are done by companies, that we can begin to accelerate the delivery of vaccines. But regardless of the success of that, there is a period of time now in which older persons, people with underlying conditions, still remain extremely susceptible to the negative impacts of being infected with this virus and can get very sick and die. We know that we can stop that. We know that we can interrupt that transmission at one level or another. We may not be able to eliminate transmission, but we have demonstrated 2 to 3 times in the last year that that is possible. Many countries have had increases of incidence over the last couple of months. We are still discussing how much of that has been due to new variants. But the fact remains that the vast majority of that increase in many countries has been down to increased social mixing, down to people not abiding by the basic measures to protect themselves, others, and their communities. And we need to redouble our efforts in that. We would say that Sweden, like all countries, needs to redouble its efforts and its population. But again, it is not for WHO. Let me repeat that. It is not for WHO to prescribe what nation states do in their sovereign interest and in relation to their sovereign relationship that governments have with their populations. We fundamentally believe that the Swedish government is acting in the best interest of its population with regard to the information that it has. All countries have to face this reality. We are there to advise. We are there to support. We are not here to criticize.
The WHO's Dr. Michael Ryan underscoring that country context, especially as what he says is a social contract that the country has with its citizenry, is very much the great determinant of the approach it takes in handling the coronavirus outbreak in its country, something that is heavy on the mind and very much shoulders of President Cyril Ramaphosa, who will address the nation